There you go. Welcome to Airway Circle Clubhouse /Zoom /Facebook Live. We have a surprise appearance with us today. So I am so excited to introduce you guys. Well, first to Roger Price and then Dr. Martha Cortes. I am going to let them introduce themselves to you and then we'll get going with our conversation tonight. Welcome.
Thank you. Dr. Price, I would like for you to, first of all, Dr. Roger Price, he's been one of the most interesting persons I have ever met. And I'm shocked at how much experience, education, knowledge he has. And also I love the way he speaks very eloquently. So Roger, Dr. Price, can you speak a little about yourself?
Well, what can I tell you? What I find fascinating is that what to me makes common sense, is simple, is something that's been around since Pontius was a pupil pilot. People look at me and say, wow, you're so smart. No, I'm not smart. I'm not smarter than anybody else. What I've done is I've read. And I've asked questions, and I've looked around, and I've seen failures, and I've seen success. And I get horribly challenged at these big conferences when specialists come up to me and say to me, what are you doing here? You're not even a doctor. And I say to them, that's from choice. I've studied enough in 63 years to have got a medical degree 10 times over. But I've chosen not to, because I do not want to be a member of an organization that limits my thinking and tells me what I have to do and how I have to do it. And I don't make a lot of friends that way in the beginning until some of them come round. And the knocker here is, the killer here is when they say to me, where's your research? And I say to them, have you ever heard of a book called Gray's Anatomy? They say, yes. I said, that's my research. Because I work with the human body in its original form. And nobody knows when that was, or how it was, or who designed it. It doesn't matter. It doesn't matter whether we're looking at various principles or philosophies in life. The fact of the matter is, the way we functioned 1,000 years ago, 2,000, 5,000. As far as the Aboriginals in Australia are concerned, the history goes back 60,000 years. If you look at Neanderthal man, and if you unearthed a Neanderthal man today and mated him with a modern woman, they would produce a child. Might be a bit strange looking, but nothing has changed much in recorded history, excepting for the way we live. Our environment, our food, our stressors. We were not designed to live in Bluetooth and Wi-Fi. We were not.
But we are.
We were not. But we are.
But we are.
And
yeah, I'm not heading to a jungle. I have a few patients that are literally moving to jungles. I have several patients moving to jungles in Mexico and Costa Rica and all that. I choose to live in the city. But we are in the city, and we do have Bluetooth, and there are more satellite towers, and there's more EMFs, and our phones are gotten stronger. They're 5Gs. We do have ley lines. If we're going to go into that whole realm, it is those things. The question is, what can we do? Not just get fed up with it. I'm not going to a jungle.
And Martha, not even.
And I'm not going to go to the pyramids. There are places I would visit. I'd be happy to be there 1 to 2 weeks, but I'm done. I'd like city. I like the city.
Yeah, but not even necessarily what are we going to do about it. More importantly is to be cognizant of the fact that these things can have effects on us that we haven't yet considered.
Well, electromagnetic fields are a big deal. EMFs are a big deal. Being in the city, there's a lot of EMFs and there's lines. And Clint Hart in Sophia Clinic out of Seattle, Washington, talks about wearing these special garments underneath that have little thin, they're protection. against the EMFs. There's protection against the satellites. So if you are that sensitive, that is the right realm to go into. So we
And
all
if you're
have to
not,
learn
yeah,
and choose.
and if you're not that sensitive, it could very well be one of the multiple underlying causes that people don't even consider because they're looking at the symptomatology, they're not looking at the etiology.
Well, the mitochondria. You're talking about the mitochondria and the ATPs of the mitochondria. If you go into the whole EMF world, because it's the mitochondria that weakens.
I'm talking about Gray's Anatomy. Okay.
Simple Gray's Anatomy.
So the essence of what I do is to try and simplify the complex, is to get to a point where stop looking at the detail for a moment and start to look at what is happening. And why is it happening? And the important thing is to drill down to the original cause. And the original cause with a human being is something called the survival instinct. We will survive against all odds, any odds, until we don't. And then it doesn't matter because we're not here anymore. So if you want to simplify the thing down to first principles, the very first thing in life a baby does is take a breath. If that breath was easy, if the birth was easy, if the birth was natural, if it was normal, if there was no intervention, if there was no Pitocin, if there was no epidural, if there were no forceps or C-sections, the baby is born relatively comfortably and it starts to breathe relatively comfortably. If, however, it is a traumatized birth, that first breath is going to be difficult. And the survival instinct will cause that infant to adopt a position, a pose, a twisted shoulder, a head back, a chin up. It will cause it to do whatever it has to do to take the next breath. That's survival. Well, if you bear in mind that for the first 6 months of life, babies breathe between 60 and 70,000 breaths a day, and you have even a minuscule compensational parafunction, breath to breath, that is where the cascade begins. And it only gets worse unless we can detect it early and bring in some remediation.
Well, the first 1,000 days are the most important days of the baby.
Exactly. And people very often don't see it, and they don't, because the infant is so flexible and so malleable, and that neuroplasticity covers multiple sins. If you don't see it, you don't think about it. But it doesn't mean that it's not susurrating here underneath the surface, causing problems down the line that we didn't anticipate. It's just the way it is. And you know, I have to laugh at Kevin Boyd. Kevin says in his practice, an 8-year-old is a geriatric. And I think that's a beautiful decision and discussion. Because anything beyond 6.
It's too late. I agree. And that's not too late, but it's pretty close to too late.
Exactly.
I agree.
So
I agree.
those first 6 permanent teeth, which come out round about age 6, those are the foundations for the eruption of the rest of the teeth. And if those 6 teeth are malpositioned, you can be pretty damn sure that there are going to be problems down the line. So go and see the orthodontist when you're 7. It's late. Okay, so who is going to drive the early identification of dysfunction? Certainly not your medical doctor, because the system gets you to see a doctor when you're already sick. The system is not designed for health. It is a disease management business. It is not a health-focused system. Therefore, we have to change something. We have to change this notion of waiting for something to happen and then retroactively or retrospectively try to intervene to alleviate symptoms.
You've touched a subject that I like, in addition to the others. But early on, I got into medical school, and I applied for dental, but also got into medical credentials and interest and all that. And what's interesting, though, that was part of my statement to them. I said, you deal only with disease. Medical is all disease based, and then you have recipes. They're just recipes. You're not really researching. You're not using common sense science. And dentistry is preventive. Dentistry can actually reverse some of the things. Dentistry, I had worked with plastic surgeons and orthopedic dentists and orthopedic surgeons that we were changing the craniofacial. This is 40 years ago. So dentistry is the answer to a lot of things, whether it's the hygienist, whether it's the dental assistant who has bigger eyes, whether the dentist, this is where, because we see everybody every 6 months.
And you start seeing them very young.
Oh, no, we see them very young. We ask for them in days old, weeks old, months old, because we want to meet the family. So we have to start teaching dentists to do earlier, at least 3 years old, at least 2 years old, and see the maturity. But also doing frenectomies on a 1 day old, 2 day old without doing any body work, I don't agree with that either.
Because it's not solving the problem.
It's not solving the problem. They are twisted.
Really? Even when they're that little?
No, they're twisted. So in craniosacral, okay, so let's go. In craniosacral, you come in with the occiput and the sphenoid, and it literally, there's a breath, there's a cranial rhythm, and it's even in the fetal. There is a breath of life. There is a certain rhythm, cranial rhythm, you may call them, but it's almost like the ocean creating tides. You know how the ocean is natural. So there are 12 cycles that come in essentially per minute of the cranial rhythms. Then after that, they're breathing. Then they come into stillbirth, into birth. And in the birth, they have that also cranial rhythm, but they can come in distorted. They have fascia distortions. So to actually release the tongue at such an early age without doing the body work, without undoing the twisting, is really not the way to go. And I'm speaking from realizing that what we've been doing all these years really is not, it's not that it's not correct. It's not the best. They need body work. They need to be released. They need the fascia. They need to be held. They need anything that's stuck inside their C1, C2. It's really essential. They need the torsion in the craniums released. So it's really an eye opener to realize that even the babies need some craniosacral work. A lot of people need more, and it's the soft tissue. It's not just the bones, and I am a bone osseous remodeler, but it's the soft tissue. You have to undo those torsions, whether you follow with the torsion or you release opposite of the torsions. That's what a lot of the craniosacral, the energy workers, it's been a big eye-opener for me to really realize how much more important that is. And that's why the therapists, the myofunctional therapists, the breathing therapists are extremely important before all these other things, and they should be doing their work first. But the dentists, the people who see them more on a daily basis are the ones that have to have the eyes and then be able to refer. So I'm actually having people do more soft tissue, more tensegrity of their actual tissues, their muscles, to put the bones and the proprioception in the right place before actually changing the osseous remodeling.
Yeah. You see, here we have something that people don't think about. The human body has 11 systems. So if you look at respiratory and nervous and muscular, I've gone back to saying skeletal instead of skeletal because I'm back in Australia. And I've also gone back to saying compensatory instead of compensatory, which I could never get my head around. Okay, so if you have a look at the 11 systems, what are the possible permutations of 11? It's 11 times 10 times 9 times 8, etc. You know that that's 40 million? You wouldn't think so starting with such a small number. But you multiply it out on your calculator and you will get 39,600,000 and something possible permutations. So how in the name of all that makes any sense is it possible to do randomized controlled, double-blinded, placebo-controlled, meta-analyzed, peer-reviewed, Cochrane validated? How can you do that kind of research when you have these organisms that are so incredibly intertwined and intercomplicated that by the time you've corrected for these things, you're left with comparing two shells? And for $50,000, you come out and you say, the red shell is different from the blue shell. Like, give me a break here. And the last line is, further research is required to find out how deep is the blue or how light is the red. I mean, it is insanity. It is insanity to demand what is not feasible. And yet, everything works on this principle of where is the research? And I challenged one specialist just before I left the US to come home. He'd been in practice a long time. I said, how long have you been in practice? He said, 41 years. I said, okay, so there's a nameless PhD candidate in a university somewhere in a small state in the United States who writes a paper. And that paper has an N of 3, and it's peer-reviewed by his professor and his fellow students, and it's published. And you are now going to draw on that conclusion and ignore your 41 years of experience. Does that make any sense just because it has been published? So he said to me, what are you saying? I said, I'm saying what Carl Sagan says. The absence of evidence does not denote the evidence of absence. Because something hasn't been published doesn't mean it doesn't work. And because something has been published does not mean that that is the optimal way of doing things. But everybody, and I say this with respect, everybody becomes lazy because they are so busy. They're so busy complying with insurance companies and legal requirements and boards and committees and reviews. They don't have time. They just accept.
That's the medical.
That is the medical, but
that is not
Martha,
the medical. Yeah.
What is dental sleep
Dental's
medicine?
trying to becoming more medical. They're trying to, but they're still not. And some of us are still looking at, we may not have the medical evidence with double-blind studies, et cetera, but you have common sense. And then you have science with common sense. That some of it's so simple. It makes me think back with perio surgeries, back 29, 30 years ago, where I would talk about lasers and speak how if someone has an infection on the toe from diabetes, and you expected that it's going to go all the way through the whole body and into the brain. But if someone had an infection in the mouth, if for some reason God was blessed it and it just stayed in the mouth, of course it's going to go to the brain. So that lasers in my hands worked really well to stop the infection. The biofilm, you could not attack it by an antibiotic because it was so deep, the periodontal infection. Nobody 30 years ago thought about this. Okay, so I've been using lasers close to 30 years because it made common sense. My patients understood, here we are, this is a laser light, it's changing the whole thing, the tissue would shrink, the infection would go out, and it would target the true infection, the pigmented actinomycosis kind of bacteria, versus waiting for all this science, which finally came through oh my God, I'm forgetting that one. But the second one was Evans in Boston. The first one was the one out of um, New Orleans University, because the research came in with blocks of bone and infected teeth and how it would regenerate in blocks of bone and teeth that people gave to the university to prove worthy that there was a change. They had they had over 200 people that did it, but then they were supposed to gift their bone sequence, their bone section block, to prove that it actually regenerated and it stopped the infection. But once it improved, nobody wanted to give away their bone and their teeth. So they only had like 20 samples, but there were about 200 cases that they did. Because once they saw the improvement, common sense medicine.
Well, the trouble with the common sense is it's not very common. That's the problem.
I use a lot of common sense.
And
Thank
what you have is this ridiculous situation.
Yeah.
If somebody sees blood in urine or in a stool, they panic. If they see blood in their mouth, they say, "Oh, I probably brushed too hard." It's a question of putting things into perspective. Oh, bleeding from the gums is nothing. It'll be okay tomorrow. So we have to try and get to a situation of understanding where we want to look at the person attached to the symptoms in as much detail as the symptoms attached to the person. And I did a program a couple of years ago called Lift Your Loop and Look. It was aimed at dentists and saying to dentists, okay, you are a registered qualified dentist, a dental surgeon. You work with teeth and you work in the mouth. So the patient comes and lies in your chair, and you get them to open their mouth, put in 17 different instruments as well as a baseball and a mitt, and then you ask them to talk. Okay, so when you've done your due diligence as a dentist, that's what I call the 4 Ds. For heaven's sake, lift your loop and look who's lying in your chair. Those teeth did not walk in by themselves and plump themselves on their chair. They came in attached to a living human being with problems, with issues, with family, with stressors, with loves, with hates, with desires. Look at what has caused what you've seen.
One of my problems in the practice is that I don't look at teeth.
Well, you see, that's why you and I are talking, and we're not talking to one of the 200,000 registered general dentists in the United States.
No, but well, you know what? I have compassion. Compassion means that I understand. And I understand my physician friends, my dental friends, and I have compassion. Compassion meaning that you have to understand what frame they're in. But like even today, I had a couple of new patients, and it's funny because I first just look at them and I listen to them. Just a little listen. I'm not asking them to give me a 40-minute dissertation of what's been going on in their life, because you also don't want to you don't want to sit there and start the relationship that way, because it's going to be continuous that way. So part of it is just looking at them and just look in their face. So you're doing facial diagnostics. You're looking at the lips. You're looking at the development of the jaws. You're looking at the possibilities where you would imagine the airway, where you would imagine the X-ray. Where would the CBCT tell you where things are? But then you listen to them speak. Are their lips enunciating? Is their tongue enunciating correctly? Is their tongue doing the THs, the thus correctly? When they swallow, are they swallowing correctly? Because right there alone, you're saying, okay, their first breath, they had a lot of trouble. They don't swallow correctly. As they're speaking, you see that they're tongue-tied. And then as they're speaking, you're looking at the incisal edges and they're wearing their incisal edges. So yeah, they have a breathing issue. And is it lifetime or not? Is it that dramatic or not? So then you look at the mandibular angle. And if it's very steep, it's been a dramatic, long lifetime breathing issues, and they may be an Eilers. You have, if it's such a high mandibular angle, they may be an Eilers. They may have TMJ, but you have to take a step back before even looking at the teeth and start asking questions like that. So I would agree with you. Who is the patient? But you don't have to elaborate, take a lot of time, because you start sometimes a relationship, there's too much talking. You're not a psychiatrist, you're not a psychotherapist, you're a dentist. But you need to look at the whole patient, because like the myofunctional therapist, you have to find out, are they breathing correctly? Is that tongue in the right place? Are they standing correctly? Are they centered? Do they have tensegrity? Because I'm taking a step back and saying those things have to be not necessarily corrected. They have to be modeled so they can do better.
They
So
have to
I
be
agree with
noticed
you.
in the first place.
They have to
And
be
this is the argument I have with a lot of the training of orofacial myology. Orofacial myologists are not myofunctional therapists, because they only understand the musculature of the face and the lips. A myofunctional therapist is a physical therapist, because they understand the myofunction, the function of the myology of the entire body. And this is where there's a disconnect. And this is where the dream team is so vitally important, that the top of the dream team is the assessor. And the assessor is there to gather data and present that data to the controlling physician, be it the dentist, be it the doctor, be it makes no difference. But to produce two profiles, the one is a structural profile and the other is a behavioral profile. And those two profiles have to be looked at together. You have to see, this is what is wrong. What is associated with it being wrong that could have been the base cause or could be an exacerbating factor after the event? And this is what I've been preaching for the last 30 years. Look after the person attached to the symptoms as well as the symptoms attached to the person. So we have this massive chasm. We have sleep medicine on this hand, and we have dental sleep medicine on this hand. And I am stumped at age 82, I am stumped to understand what is dental sleep medicine. It's got nothing to do with dentistry, it's got nothing to do with sleep, and it's got nothing to do with medicine. It is physiology, it is anatomy, it is behavior, it is nutrition, it is hydration. Then I went back to see, where did dental sleep medicine come from? And in 1975, Guilleminault and Dement created sleep medicine. And that's when they started trying to move beyond the tracheostomies to get people to breathe. And that is when Sullivan came in 5 years later with his CPAP machine. It was only in 1991, after the AASM was created back in 75, when the AADSM, the American Academy of Dental Sleep Medicine, it has nothing to do with dentistry. It was an appliance because the CPAP wasn't working. So they got hold of somebody and they said, well, what can you make? And it made a very clunky appliance. And then Keith Thornton came along later and he made a much lighter adjustment appliance, the TAP, the Thornton's advanced adjustable, whatever it was. So if we have a look at the origin of what trips off people's tongues, SDB, 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 sleep disordered breathing, it's all sleep disordered, it's bullshit. It is not sleep disordered breathing. The breathing was disordered before you went to sleep. The sleep has just aggravated it. But if you call it sleep disordered breathing, where do you start to intervene during sleep? after the event when it's too late. So I've been hitting this breathing disordered sleep concept for nearly 30 years. And I've been accused of being semantic and pedantic and dyslexic. And no, it's not breathing disordered sleep. You got it wrong. It's sleep disordered.
But you know what? The world has to start someplace.
Yes.
So I don't disapprove of sleep disorder breathing because it was an awakening. It was the eyes opening, and it's preventing many people going into metabolic syndrome, many deaths. I'm sorry, but we've had deaths in our practice. We had deaths for those young people as well as slightly older people who were the fathers, except they're only 42, 43, who died because they did not handle sleep disorder breathing because they were taking care of their 20-year-old that I was handling their sleep disorder breathing. So I think it's a real thing. Now,
Martha, it is a real thing.
Very real. So I think
but it's a red herring.
Place. It's a red herring. It's a red herring. There, yes. And I'm in this over 12 years already. And so what happens? I've had people who, very wealthy people, not want to do it because their medical insurance won't pay for it. So if they've ended up in the hospital, I go, you're going to end up in the hospital. You're going to end up having cardiac issues. You're going to end up having atrial fibrillations over nothing when you're going to handle it. And I'm not saying the CPAP. I'm talking about remodeling. Pay for it. What is money for if you don't pay for the right things? Those are my objections. I've ended up following them up and they're in the hospital. I've also ended up with those poor men who have died, who didn't do it early enough because their physicians in Harvard said, what would a little dentist know about breathing?
Right. And you know how we address that.
And that's okay. But see, my perspective is that sleep disorder breathing, sleep apnea is addressing things. So it doesn't matter to me. Now, as each person evolves, as Renata evolves, as Amanda evolves, as Anna evolves, as Angela evolves, they're going to also see that it started in the first breath.
Yes.
So they are going to start addressing all that neural aspect by doing the remodeling through the tongue, through the swallow, through the soft tissues, and they're going to get those cranial nerves in the brainstem remodeled. They're going to, the so-called neuroplasticity is the same thing as remodeling, but they're going to create it. But then there's transgressivity in the body that needs to be also addressed. But so wherever we start, it's a good beginning. And then it's up to each individual to evolve, each individual to bring it where they can with the little group that they have, because we have little groups. Our practice are all little groups. They're not ferocious 10,000 people. They're not 20,000 people.
No.
And that's okay. I like individual groups, but it's our evolution, each individual's evolution. I'm very happy to the evolution that we have had. I'm so happy to be, like today, I did a whole video in order to bring in more new dentists to understand that it's not just an appliance. It's the whole change. It's a whole complex. It's brainstem. It's C1, C2. It is the cerebellum. It is all the little nuclei of the sleep. It is the little nuclei of the respiratory that we happen to be utilizing the jaws and the teeth to expand, but to open up the whole craniofacial respiratory. So I'm so happy, but I need my soft tissue people. I need all my myofunctional therapists and my breathing therapists and my physical therapists and my tensegrity, whatever it is, but it's up to each individual to be compliant.
Okay, so let's have a look at the major problem. And the major problem is one of perception. The patient perceives the dentist as being a dentist. And they have their 20-minute appointment or 30-minute appointment, and they have other things to do, and they have children to be collected from school, and they're sitting in the dental chair in the operatory, and the dentist finishes whatever the dentist is doing to the teeth, and the dentist starts talking about what the patient thinks should be medical. But they're too polite to interrupt you. They're sitting there, they're listening to you, but they're not hearing a damn thing because they're worrying about the parking meter and the kids waiting for them at school.
And so those patients, So I've had those
These are
patients that died. I've had those patients that have died for a year and a half. Have heard me every 6 months. You have to have a sleep study. But the Cambridge physician objected. Their other physician objected because what would a little dentist know?
right.
But it is what it is. Then we go on. They finally get the sleep test and they're severe apneas. Then they go on a
Yes.
CPAP, but they're not remodeling because that's the minimum they'll do for now. Because for a year and a half, what they should have been doing was remodeling all that time. It's
So
not
let's
simple.
step back.
It's not
Let's step
simple.
back. Yeah,
But
let's
they
step back.
did something. Yeah, go ahead.
Let's step back and let's make it simple. People will listen once they have asked a question. Your voice is a transmitter, their ears are receivers. The two have to be on the same frequency before anything happens. You do not have time, chairside, to raise an issue and then defend your position that you are qualified enough to comment on that. The patient has to know that before they see you. So I'm in the middle of completing a new program called The Subtle Art of Communication, which is designed for dentists and dental teams, into how to introduce the patient to the fact that what they are going to see in that practice is a dual function practice. It's a practice where the dentist is there to look after the structural problems, and the dentist has designated a properly trained person within the practice to look at the origins. So if the front desk tells the patient, by the way, did you know that Dr. Martha has completed courses in sleep, they're not going to challenge you. And the key to any objection is to raise it first and answer it before the patient does. You might wonder what I know about sleep. Well, let me tell you, I have spent 173 hours studying sleep. Then at the end of it, they're not going to say to you, but what do you know about sleep? So the structure of what I'm doing here is to change the face of dentistry and to have a dental office be more than an operatory with a chair and a drill. I want the person to walk in and see that they've come into an environment that is an airway, a functional airway specialty, which has two divisions. It has the dental division and it has the physical division. And if that becomes the model, we're going to overcome an enormous amount of the objections that dentists spend thousands of unpaid hours trying to educate people who don't realize that they need to be educated. We need a quantum shift in what is going on because the world has moved on. We have to move on with it. So we have to take this end of the chasm, which is sleep medicine, and this end of the chasm, which is dental sleep medicine, and build a bridge. And that bridge is called functional airway. And the prime people to look after functional airway are physiotherapists, occupational therapists, licensed manual therapists, osteopathic doctors. They are the bridge between the disease and the dysfunction. And that is what will bring the whole thing into a functioning whole. Martha, in August 2018 in San Diego, at the ATS conference, ResMed brought out figures. There are 986 million people suffering from disrupted sleep, 10 times more than anybody had ever anticipated. They then said less than 10% of those are identified, less than 50% of those are successfully treated. And I think they're being vicious there too. The rest are falling through the holes. That dam is going to overflow. It is already overflowing. We will not stem that overflowing unless we can start to limit the number of people getting sick. And the only way we can limit them from getting sick is to get them early and to find out what is wrong before it becomes a chronic disease. This is not rocket science.
Today alone, or yesterday, it was yesterday. So he's now 5. My 5-year-old is walking out, that I've been treating since he was 4, as my 49, 52-year-old was walking in and looking. And I go, that's late already. He's 5. No, that's late already. He already has an anterior open bite. He has a hard swallow I haven't been able to attend. He's doing fabulous. He's really bright. So his intelligence hasn't been taken away. Because after a while, the intelligence, what do you mean? I said, after a while, that child will not be as intelligent as he is. He is 5 now. By 7, 9, he won't have the same intelligence if that breathing disorder doesn't continue. He had an asymmetrical anterior open bite. It was huge. It was really, really huge. So now it's symmetrical. It's decreased the open bite, but now I'm having trouble. And now, out of nowhere, he's getting hyperactivity.
But you know the tragedy of all of this? The tragedy is that most of that is now regarded as being normal. Because it is,
well,
it is so
he was told
commonplace.
They want to give ADH medicine, and that's why I stepped in, because we're not allowing that. But I was speaking to the 49, 52-year-old saying that's when it should have been treated, and even that is too late. And he's like, oh my God, I'm let's say 47. I go, it's way too late, but it's never too late, but it's just going to take so much work. He goes, it's working, but it's not working. I go, yeah.
We have to unwind so much
The first thing is to unwind so much stuff. And even some of it is just their behavior.
Martha, it's all behavior driven, which results in the dysfunction.
Choices, because their cingulum is not getting the right oxygen. Like in the rabbit studies at the University of Penn, the first part of the brain that doesn't get the right oxygen, when it gets oxygen desaturation issues, is the frontal cortex. Decision making, judgment,
now
anxiety.
I'm going to interrupt you here. I do not think it is an oxygen desaturation problem. I think it is an oxygen resaturation problem. Because desaturation is normal. You have to have a desat. When the oxygen leaves the bonded hemoglobin to get into the cells, you have to have a desat. That is normal. That is not panic stations. Panic stations is when you're not resaturating correctly so that you're keeping that balanced flow. But no, everybody talks about ODIs and desaturation, and the jaws drop slacked when they see that the patient is desaturating. Pop the champagne cork, for heaven's sake, if they're desaturating. But watch the resaturation. You see the disconnect in this whole thing? And it comes from this use of TLAs. Do you know what a TLA is? It's a 3-letter abbreviation. Oh, it's an RDI, and it's an 88, and it's this, and it's a CPAP, and it's an OAT, and it's a BMI, and it's a lot of alphabet soup that's being used inappropriately. You're muted, Martha.
You know what's really funny? It's happened several times to me now that a lot of people are doing abbreviations. I said, listen, I don't do abbreviations. I don't do that lingo. I'm not very good at it. I like to hear what it is. I am not in the boys group. I am not in the girls group. I want to hear what it is. Yes. Don't spell it out. I want to hear all the letters. They're like, well, everybody knows. I said, that's great. I'm not everybody, and I really don't know. I want to know exactly what we're talking about. No abbreviations.
Yeah. But life is full of
I agree with you. And then everybody nods at the abbreviations and going, damn, I don't know what they're talking about. And why can't I don't know what they're talking about. And I'm going to say it. I agree.
So we have a lot of change.
But you know what?
People are resistant to change. You know, our C does not stand for Roman Catholic. Our
You
C stands for resistance to change.
know, I'm bopping up and down. I'm bopping to the side, to the side.
Yeah.
And the reason
And that's
I'm bopping
that
is,
is the biggest single group
but
in the
yeah,
world
yeah,
are the
but what has
RC.
changed? What has changed? So when I brought in the lasers for periodontal laser surgeries 20 years ago, the problem was that it took money away from certain people.
Yes.
So there are people who just, Martha, just follow the money and you'll understand things better.
Yep.
And it's true. It's what are you changing? You're changing pockets. And that's
And
a
not
big
only the
difference for
money,
people.
follow the dogma.
Yeah.
And my
And,
karma is
and
intent on overrunning their dogma.
and like lasers for periodontal disease, for all now soft lasers. I use lasers. I used to have them brought in from Brazil for me to get my soft lasers. Yeah, I love Brazil. I love Russia too. Brazil and Russia are
Yeah.
unusual.
By the
And
way, did you know that I've been requested by 2 universities in Moscow, Sechenov and Rudin, to write special behavioral etiology courses for undergrads in medicine and dentistry?
fabulous.
I was due to
Telling
do the
you.
first semester last year, and of course, COVID got in the way.
Ah, well,
And
COVID,
now I'm
now it's
talking.
out of the
Yeah,
way.
I'm talking to Yerevan University in Armenia,
That's
and
great.
it's the countries without a lot of money that want to understand the simplicity of prevention, because quite frankly, they do not have $10,000 for ortho, and they don't have $3,000 for an overnight PSG.
You
They
know
don't
what?
have the money.
So God has the most unusual ways of working things out.
Yeah.
So I from the biological world, I had a discussion with God and go, how am I going to tell people that metals are so toxic? You know, how are we going to explain that palladium is really as bad as mercury, because some people cannot detox it out of their system? And next thing you know, God and the universe, palladium went really up. Palladium? Yeah, palladium went up really high, higher than gold. There,
Yes,
it stopped.
I
So
call them all
sometimes
kryptonite.
some
Yeah.
things work in the most strangest way. So, you know, I don't object to things not being perfect, because at least not so perfect, because some of it is being done. And then the evolution of each person realizes how it should be done better.
Yeah.
And I really respect and was in belief that there is an evolution.
Yeah. Well,
Because
what I'm doing, yeah.
lasers were garbage 29, 30 years ago. Everybody poo-pooed them. They were gimmicks
Yeah.
and they weren't. They're brilliant. Now it took 25 years to bring it to market. Now
In the 1980s, ulcers were caused by stress and too much acid.
right.
Because in the 1980s, doctors said absolutely incontrovertibly, bacteria cannot survive in the stomach at a pH of 2.5. Until my friends here in Perth proved that that bacteria burrows into the wall of the stomach lining for survival. And that is when Helicobacter came out, the pylori bacter. And then suddenly, whoops, no more bismopeptol, no more surgery for resecting stomachs, 2 antibiotics to get rid of the Helicobacter pylori. So what I'm going to be doing Friday night, I'm doing a 4-section, 4-hour webinar on Airway Circle. And that's going to be broken down into the what, why, where, how, who. It's what is the problem? So Martha, here's a question for you. You've been in practice a few years. What percentage of patients in a dental office do you think would have some kind of underlying airway dysfunction?
That is my point in every single lecture that I give, every presentation that I give about airway. I tell them, because they're like, I don't know if I want to practice. I don't know if I want to go there. I don't know if I want to do remodeling. And I just go, 65% minimum minimum is in your practice, and you will be busy for 5 years.
Yep.
Cleaning up your own practice of 65%.
But here's the problem.
It's 98%.
It's 98%, but they don't know they have a problem.
But
and
that's
they
the
don't
whole thing.
know.
But you have to wake. And my last statement is, you have to wake up to the
But they
risk.
don't know that you are the right person to fix it because of their perception. So you have to shift the practice into a secondary mode. And today, post-COVID, most dental offices are running at an 80% overhead. It's ridiculous. You work your butt off for $1,000 and you get $200 for it. I can create a second revenue stream for your practice with your existing patient base and your historical patient base with an overhead of 15 to 20%. Because you don't use an operatory, you don't use a dentist, you don't use fancy equipment, you don't use very expensive consumables. But what you do is you address your patient base differently. And you say, now with the evolution of the knowledge that we have, our dental practice now has another division to it. And that division is functional airway. But they must not see you as doing it because they won't believe it. They come in, I want you to take 45 seconds away from what you're doing and to come and see the patient and say, hi, I'm Dr. Martha. We have this new division which is run by Renata. Renata is fully trained in all aspects of functional airway, and she will be looking after you. Bless you, pat them on the shoulder and go back chairside. You've solved the problem. You don't have to do it. You just have to supervise what is being done, and you have to be the conductor of the dream team orchestra. That way you maintain your credibility. That way you maintain your position of trust with that patient who doesn't feel, what is my dentist doing messing around with medical things? It's an undercurrent of misunderstanding, but it's real. I'm working with some amazing young dentists here in Sydney. One of them has his rooms in a huge, multi-storied skyscraper. He asked me, could I please come and visit him when he heard that I'd come back from the US. So I got to this building and I walked into reception and I said, I'm looking for Dr. Khan. No, we don't have any doctors here, but there is a dentist around the corner. I wanted to smack her upside the head. Martha, I've done more of John Cortes' courses than many dentists have. And I am dumbstruck at the knowledge that dentists have, the depth of knowledge into anatomy, into physiology, into biochemistry, into bacteriology, what hygienists know. But it's not acceptable. Renata, you clean teeth. You don't know anything else because I've pigeonholed you. This is why you need this communication module. You need to have somebody to take the practice and to mold it into something that's going to highlight everybody's positions and strengthen them, not raise questions about what do you know. And that is why I believe this functional airway overriding image is the thing that is going to bring the two of them together. Maybe I'm deluded.
You're not really deluded because I've been in this so many years that now it's very easy in the practice because I have the so-called reputation, so-called following. I've had it for a very long time, but the earlier years were harder because I would tell somebody, you need to go get a sleep study because your clenching really has to do with your sleep disorder breathing. You're grinding because you are anapneic. You have a belly is because that's your cortisol.
See what you just said?
What did I did?
It's your sleep disordered breathing. It's not. It's their breathing disordered sleep that you've picked
That's
up.
also, yeah. Yeah.
Right.
Anyway,
This is the STD. This is what trips off
you're
people.
right. The communication, but some of these patients came back. Oh my God, my physician is so brilliant. Oh my God, they're so brilliant. Like really, the real New York thing. They go, why they're so brilliant. They figured I'm a sleep apneic. I said, I have it documented past 3 years, and I've requested a sleep study. So that's when I used to be nicer. Now I'm very demanding. You're getting a sleep study. You're doing a CBCT. You're doing. I used to ask and invite. Now I'm like, no, you're getting it done. And they're like, well, I don't want to. Well, then you shouldn't be part of the practice because
Okay, I
this
want
is
to
going to
bridge
hold you
that.
back. You're going to
I want
bridge
to
it. Go for it.
remove.
Go bridge it. Go.
I want to
Excellent.
remove that conflict. I want it to be set up ahead of time through communication and set up in the office that they are going to already expect it. And they're not going to challenge you when you recommend it.
But that means they would have seen you or spoken to you already, which means
Or
someone
no,
would have had to consult. How would that have had been?
no, they would be alerted that in some cases, depending on what is found, it might be necessary to have a sleep study done. This communication is a skill. It is an art. It is something nobody gets taught in medical school or dental school or hygiene school. It's something that I have taught for 60 years, how to communicate with people. And I think that that would make an incredible module for people who have the knowledge, but are not using the knowledge because they can't get through to enough people to use it, because they stymied along the way through pre-perception of who they are. We've got to do something. We've got to make some changes. Until my last breath, I will push for this change. When I was born, the word no was taken out of my vocabulary. I don't know the word no. And if somebody says to me, you can't do that, I'm all the more determined to prove them wrong. And I've been like that ever since I was a kid.
All righty. Well, Roger Price and Dr. Martha Cortes, you both have been wonderful tonight. I know you.
And by the way, I have no passion for what I do. You'll notice
None of
I'm
us
not
do.
engaged.
Why don't we ask Angela or Amanda, Tuesday, Sanelli, Sridevi,
Sridevi, Dr. Sridevi.
Dr. Savedi, to have some questions?
Yes, so I'm about to ask you guys. I have a couple pointers here that I would like to ask. I know the whole thing about myofunctional therapy. I feel like orofacial myologies, speech pathologists like to use that word a lot more, and the dental world likes myofunctional therapy. But whenever we say myofunctional therapy, we are referring to orofacial myofunctional therapy. I feel like it's just such a big name that scare people away that we have cut it down to OMT, right?
Yeah, so call it something wrong just because it's convenient and confuse people even further and draw more red herrings. That is what is wrong.
It is okay
laziness.
then? Is it okay for us to say orofacial myofunctional therapy?
It's very long, yes.
Okay.
But if you hold yourself out to be what you're not, it's going to come back and bite you.
Okay.
Because you are not a myofunctional therapist. You are a portion of a myofunctional therapist.
Myofunctional
Yeah.
therapist.
And
Okay,
I raised this at a big
up.
meeting.
Yes.
And Kevin Boyd, and I'll quote him here, he said to me, you know, you're right, but I'm going to stick with myofunctional therapy. It's easier. And this is the line of least resistance.
I know. So
you have to have your competing sides to come up with something in the middle.
Okay.
Nothing is ever right and nothing is ever wrong.
Right. Correct.
Got it?
Yes. Another thing I wanted to say is about where you were saying, when the patient comes into the dental office, being a dental hygienist, that's where the key comes in. And that's why the ADA has asked, dentists to start screening patients for disordered breathing.
Yes.
Sleep.
And if you then go to a statement by the AASM,
Mm-hmm.
and I have a copy of it, which says we need to unite and we need to stop dentists getting involved in sleep.
Well, there's not enough sleep physicians out there. They can't screen anybody. Dentists see healthy, dental hygienists see healthy patients at least twice a year. That is the whole point. It's just to help. I mean, you just mentioned that all of these people who have sleep issues are not being treated. All we're doing is just help screen them and then sending them to the sleep physicians. You're not going to go to a physiotherapist. You're not going to go to an osteopath. You're not going to go to a speech pathologist unless you have a speech issue. Usually you don't go seek these professionals unless you recognize the issue yourself. And like we just spoke about it, most people don't know they have an airway issue. Well, that's why the dental field is so important when it comes to this, because we see healthy patients, and most of our patients, lots of
All
our
right. So
have,
Renata, here's the problem. The problem is doctors are accusing dentists of practicing medicine without a license because they're getting involved in sleep, which is designated as a disease to be managed by doctors. Drop the word sleep.
Okay.
Go find and replace. And wherever you're going to use the word sleep, replace it with airway. Then they can't accuse you of practicing medicine without a license. Because you're not talking about sleep, which is a disease. You're talking about airway, which is a function. If you can't beat them, join them and then bring in another word that they can't object to.
I got it. Perfect.
It's a game.
Okay. Perfect. And another thing, we build relationships in the dental office. And it does, like Dr. Martha was saying, it does get to a point that patients just know you and they trust you and they listen to you, especially.
So what percentage of the 200,000 dentists in the United States think this way?
Not many. You're absolutely right. Not many. And it's sad because the whole dental field has gone from a service to a business. No longer people are going to look for service. It's with all the corporations purchasing.
Dentistry was always a business.
Well, right now, all this corporation
medicine is a business. No. There's nothing wrong with the word business.
Well,
functional therapy is a business.
Yeah.
There's nothing wrong with the word business. First of all, it's what is the focus of it. That's what you need to understand. There's nothing wrong with the word business.
Is the focus on the income or is the focus?
Yeah.
Is the focus on the income or is the focus on the outcome?
It's the income. I mean, the hygienists now are paid on commission. It's not about how many patients you have. It's what can you push to get them to,
You know what? Again, it is the evolution of every person. It's every practice. It's each person. It's the evolution. There have always been opportunities or evolutions. Each person has to decide where they're going to go. If I decided differently, I would be easily a billionaire. It's not my realm because that is not my focus. So each person has to figure out their focus in this lifetime.
Yes,
and then every 10 years, we all
go to a dental office and they trust them. They don't know any better. There are some dental offices here that hygienists have gone to, and they came out with a $3,000 treatment plan. And at the end, they said, by the way, I'm a hygienist. I know I don't need any of this. It is difficult for patients to trust. And whenever you are in a sole practice and you build a relationship with your patients, they trust you and they want to come see you. That is why it was so.
But they trust you because they already realize that you are truthful and you're on their side. So trust means that you care about them. Well, number one, they know that you care about them. That's trust. And the history has created that they're able to rely to say, I trust them. But it's not just the word trust, it's you care. It's not trust. Trust is an overused word. You care and you have by multiple times cared for them, that they will hear what you have to say and will follow you. They're still going to think. They're still going to look things up. My patients sometimes are much more aware of everything that I have even considered. They know their risk and management better than me. Why? Because they use the internet. They speak to other people. So, but you built a relationship, you build that you've cared and you've given them correct information.
Right.
And
But
they've
this is
got
what
them
I'm
to,
saying, Martha. You as a dentist earning X $100 per hour per chair to fund your practice don't have time.
no, I like the
We can
idea
train,
of
we
outsourcing.
can train the front office to do a lot of this for you. So they are using this third-party approach, saying, by the way, did you know that for the last 27 years, Dr. Martha has been at the forefront of laser dentistry? They're not going to question you then. They're not going to walk in and say, what's that machine? It belongs in, in sci-fi world. And I just want to take you back to 1891. Robert Louis Stevenson. He made a statement which said, everybody lives by selling something.
Right.
And how many people say, I'm not a salesman?
Well,
I can't do this because I can't
your
sell.
first, I wrote a book, I wrote a paper called the Psychology of the Smile.
Yeah.
And your first sale was your mommy to feed you.
Yes.
Period.
And that wasn't difficult.
No,
Because she was
not all babies are beloved.
No.
Not all babies are beloved.
No, look, a lot of them are resented.
Not all beloved. So therefore, that is your first sale. There is the psychology of the smile, the psychology of it. There's not, business is business, but it's your focus.
Yeah.
That's all it
You know
is.
the name?
And it's the evolution of each human being and where they want to be and where you want to take your people, your group of people. Where do you want to fly with them? Where do you want to go? Yes, I'm very philosophical. I've always been more philosophy and apply it.
We have
You know the name
done.
Zig Ziglar?
I'm done.
Yeah. You know the name Zig Ziglar?
Oh, yes.
Okay. Zig Ziglar says, I've always said that everyone is in sales. Maybe you don't hold the title of salesperson, but if the business you are in requires you to deal with people, you, my friend, are in sales.
Mm-hmm. I have a question. Veronica Cruz asked, what professional is ideal for body work for a newborn? Referring to the conversation about a traumatic birth.
Osteopath who likes babies, who likes to work on babies, because it's very, very gentle, energetic works. And osteopathy works with the cranial rhythm. And remember, the cranial rhythm may be off. Their occiput and their sphenoid may not be respiring correctly, inhaling and exhaling correctly. And there may be a torsion. And they talk about lateral strains, they talk about sphenoid strains, and they may be torsions, so they need to gently put them back so that they have the correct cranial rhythm. And also the little body is not torsion, because you can see strains along the little human body. But
yeah, you can see the torticollis, you can see all of those things, yeah.
The torticollis, the spine. They all have to be and it's just, you have to untwine them. Is that the right word? Untwine? Sometimes I mix up the words. I'm still
okay.
They're learning. My office is learning that I still almost write in Spanish that I translate to English. I don't even know that. I'm many, many years in here, but they've been watching.
You remember, Martha? I think you're of a generation who would remember this. We had a toy, and the toy was a ball, and it was made out of wood, and it had intricate little pieces carved out of it that when you put all the pieces together, there was one slot. And into that slot, you had to push the keystone, which was the piece of wood that locked all of them together.
Lock the whole thing together. And otherwise, it would be pieces.
What is the sphenoid?
The keystone.
It's the keystone.
It's the keystone.
It's the 22 bones of the skull, which through that uterine pressure and that uterine rhythm in the natural vaginal birth starts moving those bones into the correct position, slotting in the sphenoid, and the infant comes out in balance. Use vacuum, use forceps, use a C-section before this happens. If you don't have somebody with soft, sweet hands that feels the rhythm and can feel the deformity, I've done this. I mean, I have manual hands. I have feeling in my hands that connects directly to my brain. And I can feel that breathing pulse. I can feel those rhythms. I just don't do it anymore. But if it should be mandatory that at any intervention in birth, there should be a cranio-osteopath present to take the infant and to gently duplicate those uterine movements to ensure that that infant comes out in balance. But no, insurance won't pay. Isn't that just the
I purposely took the osteopathic program, and I took it with the osteopaths. It was a very hard week of manual therapy in the day.
And this was done in Florida?
I went all the way to San Francisco. I did the authentic original. But anyway, my purpose was to understand what is the osteopathy, what are the techniques, and what are we really doing? What's the purpose? And I was fascinated because there's a rhythm in there.
Of course there is.
You know, it's a natural rhythm. It's usually 12 tides per minute. It's the ocean tides coming in. Where does it come from? Is it God's hand? Is it that spark of God? And I think it is.
Nobody knows.
And they come in, they don't know, but look at the tides. How do the oceans work? There is a tide. There's a natural little rhythm, and you can feel the rhythm of those of us who can. And it was very easy for me. The program was very easy, my manual. And what happens with such babies, you feel them, they don't have the correct rhythm. They're twisted.
Yeah.
And you can feel the twisting. So I agree with Roger, Dr. Price. I call him Dr. Price. With Dr. Price.
It's so hard to say doctor.
Yeah, it's really important that it's not therapy, it's this release. And I agree with that uterine contractions. It should have been.
And you know the problem, Martha? The skulls that you worked on, that I worked on when we were training, those skulls were rigid.
They were ossified. I agree.
They were rigid. Yeah.
I know. I agree.
No, the skull doesn't move. Yes, the skull does move.
It does.
That's what the sutures are for.
It does. Yeah. Anyway.
That's it.
Guys, we have gone over.
Renata, I am leaving.
Yes.
Good night, everybody.
You guys are fantastic.
It's wonderful.
Thank you, Dr. Martha, for showing up last minute. I really, really appreciate it.
You're welcome. It's a pleasure to be with Dr. Roger. Dr. Price to me is unbelievable. So thank you.
Priceless.
The opportunity.
Well, it's a joy being here, I can tell you.
Roger,
I could be salmon fishing in the Yemen, but that wouldn't give me half the satisfaction.
Roger, we'll see you on Friday.
Bye, everybody.
I cannot wait to have everybody over there. If you guys have not signed up yet, go to our Instagram.
We'll see you Friday night.
Yes, Friday night at 6 p.m. Eastern Standard Time. You get 4 hours of CEs for dental professionals. And we have Dr. Kimberly Santiago on Thursday night at 8 p.m.
Yep.
And that's,
by the way, she's a dear friend of mine.
Really?
And Kimberly's done quite a lot of work with me.
Oh, wow. She's fantastic.
Yeah, she's amazing.
Clubhouse before, so now we have her on Zoom. But anyways.
A dynamo, a human dynamo.
Yes.
Yeah.
Thanks, everybody,
guys.
who listening tonight. Thank you, Roger. Sorry, we went way over time, but I hope you have
all of you. My day is beginning.
Over there.
See ya.
Bye.
Bye.
Bye.